Okay. 25 men brought to the ED by ambulance 25 minutes after his wife found him unconscious on the floor at home this morning. He was discharged from the military 3 months ago after he sustained a traumatic brain injury and underwent right below the knee amputation. Since his return, his family says he has had mood swings, aggressive behavior, anxiety, which have prevented him from interacting with people. He has MDD and severely in pain. Medication amitriptyline, sertraline, oxycodone, acetaminophen. 2 days ago, he began short-term course of alprazolam for persistent anxiety. His family says he generally has been adherent to his medication and cognitive behavioral therapy regimen. He does not smoke cigarettes. He drank 12-ounce beer weekly as a teenager. Now he drinks 12-ounce beers, 8 12-ounce beers weekly. I don't know what that means. On arrival, he's somnolent and responds to painful stimuli only. Temperature is normal. Pulse is high. Respirations are low and shallow. And blood pressure is low. Pulse oximetry, oxygen saturation is 92. Exam shows warm, dry, flushed skin. Pupils are mediatrix or big. With nystagmus. Hair movement is decreased in the lungs. Cardiac exam is fine. Abdomen is soft. Bowel sounds decreased. Patella detent or reflex 3 plus. An overdose of which of the following is the most likely explanation?
Okay. This patient has likely attempted suicide by overdose of amitriptyline, tricyclic antidepressant, overdose presents with anticholinergic adverse effect, hyperthermia, flushing, mydriasis, ileus, and urinary retention, and cardiac arrhythmia, generally wide QRS complex tachycardia. Neurologic manifestation include mental status changes, decreased level of consciousness, delirium, and seizures. Resuscitation can include intubation for patients for protecting the airway with respiratory failure. The administration of sodium bicarbonate to treat cardiac toxicity, and the administration of IV fluid to correct hypotension. A dose of activated charcoal any may be given to bind any remaining intraluminal drug, but should be but should only be used if airway is protected. The mainstay of treatment for TCA overdose is sodium bicarbonate. And the mainstay of treatment for TCA overdose is sodium bicarbonate. A broad a broad set of lab studies should be sent to assess for end organ dysfunction and co-ingestion.
Okay. Next. 29 woman comes to physician for routine. She has no history of serious illness, no medications. Menses occur at regular 28 intervals, lasts 5 days, and accompanied by mild cramps. Last menstrual period was 3 weeks ago. She's sexually active and monogamous with one male partner. She has a copper IUD. Blood pressure is fine. Physical exam shows no abnormality. Pelvic exam shows IUD string at the cervical os and a mildly tender right adnexal mass. Transvaginal ultrasound shows a normal uterus and left adnexal and 5 centimeters hemorrhagic cyst in the right adnexal. Which of the following is the most appropriate next step? Hemorrhagic cyst.
What is your diagnosis?
Like normal cyst. I don't know. Like menstrual, whatever cyst that happening between menses.
Okay. The corpus luteum develops from the mature follicle after the egg has ovulated during menstrual cycle. After the egg has ovulated during menstrual cycle, in some instances, the corpus luteum can form a cyst which can remain asymptomatic or potentially rupture. While a cyst may remain asymptomatic or and may be found incidentally on physical examination, a ruptured corpus luteal cyst classically presents with unilateral pelvic pain or lower abdominal pain that is severe and sudden in onset, often after sexual intercourse or physical activity. Pelvic ultrasonography will show a complex cystic mass if unruptured or free fluid in the pelvis, which may include hemorrhagic components of the hemoperitoneum. Corpus luteal cysts are generally managed with supportive treatment and surveillance as this patient has unruptured stable cyst. As this patient with unruptured stable cyst, the most common appropriate next step in the management is the repeat transvaginal ultrasonography in 6 weeks to ensure its resolution.
20 semi-gravid a woman, 28 weeks gestation, is brought to the emergency after she was involved in a high-speed motor car accident. She was the restrained from passenger. She has no history of serious illness. Pregnancy had been uncomplicated. She has moderate neck and back pain and abdominal tenderness. She appears confused, temperature fine, pulse high, respiration high, but BP low. Vital heart rate is fine. Exam shows multiple facial contusions. Lab study shows hematocrit. Really, that's low. Let me check. In addition to continuous fetal monitoring, which of the following is the most appropriate next step in management? Yeah, hematocrit is low. Everything else is fine.
Okay. The initial evaluation of a critically ill patient. The initial evaluation of a critically ill patient includes assessing the airway, breathing, circulation, central nervous system, and any external threat to morbidity and mortality. After blunt head injury, patients can present with concussion or traumatic intracranial hemorrhage, such as subdural hematoma, subarachnoid hemorrhage, or epidural hematoma. A young patient with altered mental status and signs and symptoms uh, and signs of trauma to the head raises concern for traumatic intracranial hemorrhage. CT scan of the head is critical for diagnosis of a patient with head trauma. CT scan of the neck is also indicated in patient with neck pain and altered mental status. Neck pain and altered mental status in a high speed blunt traumatic injury, although in a high speed traumatic injury and the risk of mother and therefore fetus is high and radiation outweighs the risk benefits of radiation outweighs the risk in such cases. Okay.
Okay, next. 15 boy brought to the physician because of fatigue since starting his freshman year of high school 3 months ago. He often falls asleep during class. He urinates 4 to 5 times nightly and often has difficulty falling asleep again. Has no history of serious illness, no medication. He's at the 20 percentile for height and 95 for weight. So he's short and fat. Vital signs are normal. Exam shows a velvety and hyperpigmented macular rash over the neck and axilla. The remainder of the exam is fine. Hematocrit is low. Leukocyte count fine. Platelet a bit high. Sodium low. Potassium normal. Chloride normal. Bicarb normal. Urea normal. Glucose no. Glucose is high. Wait, yeah. Creatinine normal. pH acidic a bit. Glucose 2 plus in the urine. Urine pH is acidic. Ketones negative. This patient is at greater risk for which of the following complications in his current condition during the next 15 years?
Okay. Type 2 diabetes mellitus can be asymptomatic and presents with polydipsia. Type 2 diabetes mellitus can be asymptomatic or present with polydipsia, polyuria, acanthosis nigricans, diabetic ketoacidosis, hyperosmolar hyperglycemic state if severe. While there are several acceptable diagnostic criteria, where there are accepted diagnostic criteria, commonly employed criteria include hemoglobin A1C. Commonly employed criteria is hemoglobin A1C greater than hemoglobin A1C above greater than or equal to 6.5 or fasting glucose concentration greater than or equal 126. The Framingham Heart Study identified a roughly twofold increase in the rate of coronary artery disease in patients with a roughly twofold increase in coronary artery disease is increase in patients with diabetes. Patients with diabetes also increase risk of extens increase extensive multivessel coronary artery disease. In addition, diabetes mellitus, childhood or adolescent obesity is a risk factor for premature development of coronary artery disease in patients for type 2 diabetes mellitus include weight loss, lifestyle modification with the addition of oral antihyperglycemic. If these modifications are unsuccessful, a multifactorial approach is necessary to reduce the risk for developing coronary artery disease by controlling hyperglycemia and other risk factors such as obesity, hyperlipidemia, and hypertension. Okay.
Uh-huh. Previously healthy 2-year-old boy who is scheduled for an elective operation begins to cry and cling tightly to his mom on arrival to the hospital. Which of the following is the most likely cause of this behavior?
Okay. Separation from a caregiver often leads to fear and distress in children, which is referred to as separation anxiety. Separation anxiety is a form. Separation anxiety is a common young children, especially those between age 18 months to 3 years. Children around this age have not developed object permanence or the idea that items out of their sight continue to exist. Separation anxiety can become even more apparent in unfamiliar situations such as healthcare system. This 3-year-old this 3-year-old patient with approaching an unfamiliar location is demonstrating crying, and clinging, which are common symptoms of separation anxiety, likely related to fear of being separated from his mother. Okay,
You read E as in
yes,
E. Mhm.
stranger anxiety. Stranger anxiety stranger anxiety is also common in children and manifests as fear, avoidance, and avoidance of stranger. It is more common in children from age 9 months to 2 years. This patient has met any strangers yet in this scenario, making her fear of separation from his mother the more likely cause of his presentation. Okay.
Next. 19 woman brought to the ED by her mom. 30 minutes after ingestion of an unknown liquid she found in her parents' utility room following an argument with her boyfriend. After swallowing the liquid, she telephoned her mom at work, who arrived 20 minutes later and found her daughter drooling and reported severe upper chest pain. On arrival at the ED, the patient is in obvious distress and drooling, unable to swallow. Temperature is fine, pulse is high, respiration fine, BP high. Physical exam shows profuse clear drainage from the mouth and redness edema of the posterior oropharynx. The pulmonary exam is fine. Two large bore IV catheters are inserted for fluid administration, and a dose of IV hydromorphone is given. The patient begins to feel more comfortable. Results of last study are within reference range. Chest X-ray is fine. Which of the following is the most appropriate management?
So, what is your diagnosis?
I don't know. He ingested something. I don't know what she ingested. I don't think you can know what she ingested from the.
Ingested some liquid in his house, like Harpic. Okay. This patient present after an acute ingestion, likely ingested a caustic household chemicals. Drain cleaners are the common causes of caustic ingestion. They contain hydroxides, alkali, that are proton acceptors and strong nucleophiles. Alkali ingestion leads to liquefactive necrosis, lactic acidosis, and tissue penetration and ulceration. It can cause chemical burns and ulceration of the tongue, airway, and esophagus, and resulting in stridor, hoarseness, vomiting, and drooling. If severe, uh, if severe esophageal perforation can result, leading to leakage of gastrointestinal contents into the mediastinum. Treatment is initially focused on supportive measures including airway management and fluid resuscitation. Visible lesions in the oropharynx increase the likelihood of the distal gastrointestinal lesion. Patients should be evaluated with esophagogastroduodenoscopy to assess for visceral injury. For severe injuries, treatment involves corticosteroid administration, antibiotics, surgical intervention in cases of perforation. Okay.
Uric A.
Yes, activated charcoal would not be safe for a patient is drooling and unable to swallow and has limited ability to protect the airways and has limited ability to protect the airways. Charcoal, if okay, Charcoal, if aspirated, can be harmful. I don't know why my Gemini starts automatically. Okay. Charcoal, if aspirated, can be harmful to the pulmonary parenchyma and can cause aspiration pneumonitis. Activated charcoal can obscure the results of esophagogastroduodenal. Do you remember the chart of the blunt chest trauma? Like we have done a question where the CT chest was the answer. So when we do the CT chest, like if a patient with like hemodynamically unstable, then we do the resuscitation and the E-fast chest X-ray ECG with or without stabilization, like chest tube, if indicated. If hemodynamically stability achieved, then we do the additional CT. If the hemodynamic stability achieved, if hemodynamic stability not achieved, then we go for thoracotomy in hemodynamically unstable patient. And for hemodynamically stable patient, if there is high risk mechanism, again we do the like apart from E-fast, we do chest X-ray, ECG, and if hemodynamically like patient is stable, some sort of, then we do additional CT chest. And no, like hemodynamic stability stable, like no problem, possible discharge for observation. If no problem on the chest X-ray or ECG or CT, if there is no problem, then possible discharge or observation. So on that question actually,
This is not a blunt chest trauma question.
yeah, like the 41, the like the previous question we have done, high speed
Oh,
motor vehicle collision, that one.
okay. Let me see the 41.
43 as
This one, head and neck,
you
the pregnant.
you're yes, now yes, this one.
Okay.
uh we should how this, how we will match this question, like isn't it we consider it as a blunt chest trauma?
Not really. I don't think it's considered a blunt chest trauma. Blunt chest trauma is usually like you will see bruises on the chest or fall from a. I think it's the fall from a building. I don't know. I don't even think
There
that's.
is multiple facial contusion.
Yeah, but blunt chest trauma is to the chest. But here is facial contusions. It's to the face.
So as there is facial contusion, that's why a neck is added,
No,
or
no,
neck is
it's
added due to he has neck pain.
neck pain. Yeah,
Where the neck pain is written.
it's right here.
Okay, yes, yes, neck and back.
Hmm. Yeah, makes sense.
Yes.
Okay.
So we will not consider it as a blunt chest trauma.
No,
Okay. I'm trying
23
to make the question fall into different categories.
categories. No, I mean, but you did describe. I didn't even remember the whole bunches drama thing chart. So, but you did
Uh,
actually did describe it good still.
as far I am solving the question, I have seen that there is a pattern of question. Like
Mm-hmm.
they follow the pattern.
Mm,
Okay.
interesting. Okay. 23 male college student comes to the clinic for follow-up visit 14 days after undergoing emergency splenectomy for a car accident. The patient has resumed his regular diet and ambulating normally. Medical history is otherwise fine. His only medication is acetaminophen as needed. The patient completed his Hemophilus type B vaccination at age 18 months and his varicella, polio, and MMR. By age 5 years, he received HPV vaccination at 11. Temperature is fine, pulse is fine, BP, I guess a bit low. Abdominal exam shows well healing, midline incision. Which of the following is the most appropriate to administer to this patient today? He underwent splenectomy.
She under okay. Hemophilus influenzae type B. Because in splenectomy, like the shine infection happens mostly. Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitis. Asplenic patient. Okay. Asplenia. mm, Can you tell me the pathologic finding found in the asplenic patient in the peripheral blood film?
Oh my God. Please
Howl
look at
jolly
his
body is this
house.
howl jolly body?
Yeah. House
Howl jolly
Jolly.
body, thrombocytosis, lymphocytosis. There is another thing. It is,
I don't know.
oh, okay. Target cell. Halt, like the halt, hemolysis, asthenia, liver disease, and thalassemia. Target cell, halt.
That's
Do you remember?
Yep.
Okay. I am doing this for myself. Extremely sorry
Oh,
for
that's
the
good.
interruption.
No, it helps me also. So please do it.
Okay.
It helps me remember, yeah.
Like a random thing comes in my
Mm-hmm.
mind, and I'm asking you
Mm-hmm.
for clearing my concept. Okay. Okay. Asplenia can occur because of congenital anomalies, splenectomy after trauma, and splenectomy, splenic, splenectomy after trauma. Because why I am saying so? Because as the day passes, I am realizing that whatever we study, uh, it will not gonna help in the exam. That
Yeah,
the
because
residual thing
there is,
in your
yeah.
brain, it will only help because I am forgetting everything, like I am starting
No,
forgetting.
you think you are forgetting, you're not. You think you're forgetting, you're not. It's just gonna take you more time to access it.
Yes,
That's it. Yeah, it's gonna take you more time to act, but you are not for. But I get what you're saying because it feels like the first ones that we were doing, the first like GI and
yes.
like
Ev-
yeah, it felt like
yes, everything actually fades out.
mm-hmm.
Okay.
But no, you don't remember. You don't remember.
Yes. So asplenia can occur because of congenital anomalies, splenectomy, splenectomy after trauma, and or because of chronic vaso-occlusion and infarction in conditions such as sickle cell disease. The spleen removes the opsonized pathogens and infected cells by mechanical infiltration in the sinusoids by phagocytosis and by splenic macrophage. Additionally, the spleen houses the immunoglobulin producing B lymphocytes. The patient plays an important role in the clearance of encapsulated pathogens such as Haemophilus influenzae, Neisseria meningitis, strep pneumoniae, among others. Asplenic patients are at risk of infection with encapsulated bacteria, making vaccination against encapsulated bacteria such as Haemophilus influenzae and the most appropriate for this patient. Okay.
Next. Previously healthy 90-year-old college student comes to the ED because of a 3-day history of lower abdominal pain and vaginal spotting. Menses usually occur regular 28 days, but she cannot recall the date of her last menstrual period. She takes no medications, is sexually active, and uses condom inconsistently. She appears pale but is alert and answers questions appropriately. Pulse is high, respiration high, BP low. Abdominal exam shows lower quadrant tenderness with marked gagging. Pelvic exam shows a soft uterus and a nasal tenderness greater on the right than on the left. hemoglobin concentration is super low, hematocrit low, serum HCG concentration is high, urinalysis shows no abnormality. Which of the following is the most appropriate next step?
Okay, what is your diagnosis?
Like some type of pregnancy or ectopic pregnancy.
Okay, if methotrexate is the option, is is methotrexate is possible?
I don't think so here because she's unstable.
Sorry,
I don't think methotrexate will be an option here because she's unstable, right?
yes, she's unstable. Yes, 1 point, and there are some other criteria like if beta ECG is more than 5,000, if there is fetal cardiac activity, these patients beta ECG is more than 5,000, so we cannot give methotrexate. And Doppler has not done here. And ectopics, if ectopics mass size is more than 3.5, then methotrexate cannot be given. Okay, this
Repeat it again.
if
Repeat the
beta
next.
ECG is more than 5,000,
Mm-hmm.
or there is fetal cardiac activity, or if there is ectopic mass more than 3.5 centimeter, then beta ECG. Sorry, then contraindication of then methotrexate is relatively contraindicated.
Mm-hmm.
Okay, this is for evaluation of ectopic pregnancy.
So this is not this one, right?
Yes.
Oh, it's
Okay.
not. Oh, okay.
It is for evaluation. It is not the methotrexate giving criteria. Like
Okay.
there are some contraindication in hepatic disease and renal disease. Methotrexate cannot be given, and I am adding something. I have read somewhere. I don't know where, but there is like beta ECG criteria. Like if beta ECG is more than 5,000, then there is relative contraindication to methotrexate therapy.
Okay.
Okay.
Yeah. Okay.
Okay.
Um,
Pregnancy is pregnancy is suspected when there is missed or delayed menstrual period. An ectopic pregnancy is an abnormal pregnancy in which the fertilized ovum implants in the fallopian tube, which is most common on the ovary within the peritoneal cavity, or in any non-endometrial location. It often presents with vaginal bleeding and abdominopelvic pain. Beta ECG concentration will be detectable. The pregnancy may be visible on ultrasonography. Are non-viable Ectopic pregnancies are non-viable. Small and early pregnancy can be managed medically with a methotrexate area. Complication of unrecognized ectopic pregnancy is rupture leading to bleeding and hemoperitoneum. In this instance, physical examination may show and abdominal guarding. Severe cases may be lead to hemorrhagic shock or with tachycardia, hypotension, and anemia, as seen in this patient. Treatment of the rupture ectopic pregnancy is emergent exploratory laparotomy along with fluid and blood product resuscitation. Okay.
Next, 17 boy brought to the office by parents. because of changes in his behavior during the past 6 months. They say he has become withdrawn and moody and has that his grades have declined. He has returned home from parties intoxicated 3 times during the past month. During a wedding reception 3 weeks ago, he was delirious, incoherent, and imbalanced. The patient says he drinks alcohol, but that his drinking is not a problem. He can stop drinking whenever he wants. Vital signs normal, physical exam shows no abnormality or mental status. He's calm and cooperative. He reports no insomnia, hypersomnia, or suicidal hallucination. Um, the diagnosis.
Okay, what is the point of alcohol use disorder?
What do you mean?
What are the points of alcohol use disorder?
Oh, he. I mean, he said he's drinking, and I mean, he's obviously been
Why it is
intoxicated.
not recreational alcohol use?
Oh, because he says, I mean, he's come home drunk. So it cannot be that he's come home drunk like 3 times in 1 month. And then he says that, oh, I can stop drinking whenever I want. So he doesn't see he has a problem, but people around him see that he has a problem. So that's like one of the is that one of the cage questions? I don't know, but it's like one of the things. Um, yeah.
Okay, alcohol use disorder refers to an addiction to alcohol must meet at least two of the following criteria: inability to cut back on drinking and drinking more than expected, and excessive time spent drinking, and alcohol cravings, persistent drinking despite physical or mental problems related to drinking, and persistent drinking despite negative social consequences. Alcohol use disorder is a clinical diagnosis. Alcohol use disorder is a clinical diagnosis made by the presence of personal, professional, emotional, behavioral, and physical disturbance related to the use of alcohol or attempts to reduce intake. Symptoms may be classified as mild, moderate, or severe depending on the number of domains affected. Alcohol use disorder can occur in adolescent. Alcohol use disorder can occur in adolescent and is associated with negative social and academic consequence as well as increased risk for high risk sexual behavior, accidental death, and suicide. And why it is not recreational alcohol use? Recreational alcohol use is distinguished from the alcohol use disorder by moderate use and absence of dependence and negative consequence associated with drinking. Recreational alcohol use as adolescent is not illegal in US. From which age US people can have alcohol?
I think it's 21.
Sorry,
21. 21.
21 is okay. Then how the school going
Mm.
people can do the alcohol party?
Oh, I mean, it's illegal. That's why I say, I mean, you can go and do it, but it's just
Okay,
not.
it is not legal like in the bar. You can not buy in the bar. Maybe,
Yeah, you cannot buy it in the bar. I mean, if
but
you
you
have a
can
paper and
have alcohol anywhere else. Okay.
no, 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 you cannot have alcohol. No, no, you cannot go to a party and be less than 21 and drink alcohol. You cannot. It's illegal. Yes.
So in the movies, the people who are having alcohol, they are actually little one.
Yeah, but usually you get a fake ID that says you are 21 or you are
Okay.
22. Yeah, and you can use that. Not that I did it. I'm just saying you can do that.
Sorry.
I have not done it. I'm just saying like you can do that. I never done it. I'm just saying.
I haven't said anything
No,
about
I'm just
this.
just making sure I haven't done it. I'm just saying
In our religion, it is prohibited, and I haven't, inshallah, I haven't
you
take
haven't
any
tried.
sip of alcohol.
You are
Not
not
even. Sorry.
you are not curious.
No,
You are not
no, I
no
am not curious. I'm not that curious. I'm very old. People call me uncle.
uncle.
Yes,
I don't
trust
know
me. The trust me, in the road, lots of people call me uncle, and I don't have any problem to them.
with them.
Maybe
My
I look like uncle. That's why they say so.
my best friend is Muslim, and so at the begin when she came to the US, because we met here in the US, she was like, "No, it's against my religion," but But then
Oh,
she was like, "Okay, she wants to try it." She tried it, but she doesn't. It's not like she does it every day. It's only when we go out she'll try. But you don't see any alcohol in her
no,
at her house, in her home,
like
nothing.
in our religion, if you take a sip of alcohol, like it persists in your digestion system for more than 40 days.
Oh,
Maybe
jeez.
it is written. It persists in more than 40 days. So your 40 days prayer will not be counted.
Will
So
not count.
yes. So if you take alcohol weekly, then and you are carrying this, that means your whole prayer is going to in vain.
Goes nowhere. That's how. That's why. Okay.
Okay.
Get it.
So I'm not that curious. I'm
You're not that.
curious. I am curious about plenty of things, like I like sports and I have done multiple sports.
No, but I get it because my husband is Muslim too, and when I was like, I drink. I'm not gonna, I don't drink all the time, but I drink when I go out. But since I've been with him, I'm like, he doesn't. It's not like he tells me not to drink. He doesn't drink. I drink whenever I want, but he doesn't. But since I just feel like it's not, I don't even need it. Like
Yes,
I don't know when was the last time I had a drink. Probably like 2, 3 years ago. And I don't have a problem with alcohol. Like I don't mind drinking, but I just don't feel the need. I don't know. I don't know now.
drinking is bad. Yes.
Yeah, I don't know. Maybe because I'm studying, so that's why I'm like, no, I don't care. I don't care about that. Maybe once I pass my step two, I'll just go out and to
So
celebrate.
you drink as because you are so stressed for relieving your stress like that.
No, like when I celebrate, like if it's somebody's birthday, we
Okay.
go to the birthday and I drink, or if I pass my step two and I want to celebrate, I'll go out and I'll drink,
Okay.
something like that. But I think because I've been stressed all this time with the exam, that's why I just haven't had even time to drink or anything. I don't know, but yeah. Okay, let's leave the alcohol. 47 woman comes to the physician because of 9-month history of hot flashes, night sweats, and pain during sexual intercourse. Her last menstrual period was 1 year ago. Physical exam, no abnormalities. Pelvic exam shows vaginal atrophy, and non-cervical mucus. Okay. Pap smear and mammograph show no abnormality. Which of the following is the most appropriate next step? Mm.
Okay. Menopause refers to menopause refers to the absence of menstruation for menopause refers to absence of menstruation for a year caused by diminution in ovarian reserve. On average, it begins around age 50. It begins On average, it begins around age 50. Symptoms include hot flashes, night sweat, and vaginal atrophy or dryness, and mood and sleeping patterns. Mood and sleeping patterns may be affected while it is commonly clinical. While it is commonly a clinical diagnosis, a lab studies will show increased follicle stimulating hormone and decreased estradiol concentration as symptoms of menopause are secondary to estrogen deficiency, which can increase the risk of variety of health problems. Osteoporosis hormonal therapy with supplemental estrogen is considered, while estrogen therapy while estrogen therapy while estrogen therapy does relieve the symptoms, it is not without risk. Prolonged exposure to unexposed antigen, prolonged exposure to unexposed estrogen can increase the risk of endometrial cancer, cardiovascular disease, thromboembolism, breast cancer. The recommended duration of use is limited to 3 to 5 years for this reason. Okay.
Okay. Next. 60, oh, last section. 67 woman comes to the physician because of a 2-month history of perirectal pain that worsens with bowel movements and a thick yellow rectal discharge. She has hypertension, psoriasis, medications are metoprolol, topical fluni, I guess steroid cream. There is no family history of serious illness, no smoking, no alcohol, no drugs. Temperature is fine, pulse is fine, respiration fine, BP fine. Abdomen is soft, non-tender, not distender. Rectal exam shows brown stool. The skin of the posterior perineal wall is edematous with draining sinus tract. Test of cold blood is positive. Which of the following is the most likely diagnosis? Hmm.
So, Crohn's disease has only propensity of having fistula. So, Crohn's may be the answer.
Mhm.
Fistulating Crohn's. And in fistulating Crohn's, like we can give infliximab, adalimumab, this type of drugs.
Mhm.
Crohn's disease is characterized by Crohn's transmural of the GIT, most frequently involving the terminal ileum. It can arise anywhere in the GIT. It can arise anywhere in the GIT and is subclass of inflammatory bowel disease. Most patients experience chronic abdominal cramping, bloody diarrhea, and weight loss. Examination often discloses generalized abdominal tenderness, sometimes worse in the right lower quadrant, and depending on the severity and the extent, may disclose complications such as enterocutaneous fistula and extraintestinal manifestations such as uveitis. Severe Crohn's disease can result in intestinal obstruction from stricture or inflammation, bowel perforation, intra-abdominal abscess, or the formation of the fistula. Diagnosis occurs through imaging and biopsy, and lab studies often show increased erythrocyte sedimentation rate. C-reactive protein on fluoroscopic small bowel follow-through narrowing of the intestinal lumen at the terminal ileum is commonly seen, along with the site of stricture or the fistula's formation. Treatment include anti-inflammatory medication, immunomodulators, glucocorticoid. Complicated severe cases may require surgery, including small bowel resection or colectomy. Okay.
With E, ulcerative colitis.
Ulcerative colitis is a type of inflammatory bowel disease that presents with ulcerative colitis is inflammatory bowel disease that results in mucosal or submucosal ulceration, and inflammation An, an inflammation that progressed to retrograde along the colon from the rectum. This typically presents with chronic bloody diarrhea, tenesmus, abdominal pain. In contrast to Crohn's disease, transmural inflammation associated sequelae including bowel perforation, intra-abdominal abscess or fistula are less common.
Okay. Next. 12 hours after discharge from the hospital, 2-day-old male newborn
Can you
is.
tell me the some difference between the Crohn's and the ulcerative colitis?
Oh Lord. Another Crohn is the transmural one, and the one that has like a lot of complications. The ulcerative colitis, I think, is the one that's with the PSC, with the
Yes,
liver. What else? The fistula and all that is the Crohn's.
yes,
Ulcerative.
fistula, abscess, stricture is for Crohn's. Ulcerative colitis along associated with PSC, yes, and there is a complication like toxic megacolon. We found that
Yeah,
toxic
toxin
megacolon,
and
more than 6 centimeter of the bowel and
yeah.
coffee bean shaped. Okay,
Wait, no. Toxic megacolon don't have the coffee bean shape.
toxic isn't it? Toxic megacolon is coffee bean. Oh, sigmoid volvulus may be coffee bean shaped.
Sigmoid volvulus.
Okay.
And then there is something about the something.
Granuloma is for Crohn's. Crohn's causes non-caseating granuloma, and C for Crohn's, C for cobblestone, C for
Oh,
cobblestoning is seen,
God,
creeping fat is seen.
sleeping fat, yes.
So cobblestone, creeping fat, and Crohn's is like transmural, and ulcerative colitis is mucosal and submucosal inflammation.
Yeah.
And ulcerative colitis usually uh, what can I say, is continuous lesion, not like skip lesion. So if you do surgery, the best outcome comes in ulcerative colitis than the Crohn's, because
Okay.
in Crohn's there is skip lesion.
Stipulation. Yep. I remember.
Okay,
Yep. 12 hours after discharge from the hospital, 2-day-old newborn is brought to the ED. After having a seizure, his parents report that he stiff and his eye rolled back for 2-3 minutes. He, he then went limp. He was delivered vaginally at term to a 20-year-old woman gravid at 1 following uncomplicated pregnancy. Weight on delivery was 6 pounds. The patient mother used to drink 2 glasses of wine each evening. With dinner, but stopped drinking alcohol when she learned she was pregnant at 4 weeks. She has never smoked and doesn't use drugs. On arrival, the infant is awake but sluggish. Exam shows hypertelorism and lucid ears. Lungs are clear. There are no murmurs. Checks X-ray shows narrow mediastinum and right-sided aortic arch. Wait, right-sided aortic arch. Okay.
what is your diagnosis? Hypertelorism, low set ear, hypertelorism, low set ear, hypocalcemia, not
Oh,
given here.
not given. When you say hypercalcemia, I know, I know it's the George, but it's not given. Yeah.
And the chest X-ray showed narrow mediastinum and a right-sided aortic arch. Is is it
I,
the meaning of thymic aplasia?
I'm guessing that's what they mean by narrow mediastinum. I don't know the right aortic arch, but I guess narrow mediastinum, that's what they mean. Like, no timing. Yes. Right-sided aortic arch, right-sided. Okay, because it's supposed to be on the left, I guess.
Yes.
Yeah. Okay. Mm,
Okay. Thymic parathyroid dysplasia. Thymic parathyroid dysplasia. DiGeorge syndrome is a disorder caused by microdeletion of 22q11 chromosome which results in abnormal development of third and fourth pharyngeal pouches. It presents in early childhood with thymic hypoplasia and impaired immunity, conotruncal cardiac defect, truncus arteriosus, hypocalcemia caused by parathyroid hypoplasia and craniofacial abnormalities such as low satire, hypothyroidism, micrognathia, cleft lip and palate. It is associated with developmental delay. Severe hypocalcemia can lead to seizure as in this patient, as well as laryngospasm, bronchospasm, and emesis. Lab evaluation will show leukopenia and low calcium concentration, while a chest X-ray may show the absence of thymic shadow as well as narrow mediastinum and right-sided aortic arch, as in this patient. Further evaluation typically includes echocardiography and renal ultrasonography. Treatment is supportive, and calcium repletion is critical, especially in cases of seizure. Okay.
Okay. 2-year-old girl brought to the physician for a well child. She has had 2 UTIs since birth. She has not had pain with urination or urinary frequency or urgency, but she has had 2 UTIs. Okay. Exam shows no abnormalities. Renal ultrasound shows no obstruction. Voiding cystourethral shows grade 2 vesiculourethral reflux.
Okay. Mm, okay. This patient, it was that question like age 2 years,
Yeah, I remember.
renal and bladder sound ultrasound followed by voiding cystourethropy.
Mhm.
But this patient has viewer grade 2, so antibiotic. Viewer grade 2 is antibiotic.
You get to observation and okay,
With or prophylactic antibiotic.
okay.
And in 3
So,
and 4, prophylactic antibiotic with or without surgery.
but which one is the one? The if you had the UT? Oh, this one.
This
So this
one.
patient is what 2 years? Is exactly two, but it's not her first UTI, so you cannot observe. Since it's recurring, you do the
he,
ultrasound, which they already did.
he has recurrent UTI. She has two UTI since birth.
So they already did the ultrasound, and they
They
already did
already
the.
did ultrasound. They did voiding cystourethrogram. So they followed this pattern. And in voiding cystourethrogram, if abnormal, then it goes to that chart. You got my point. Voiding cystourethrogram shows that it is VUR. Now you found it is VUR and you need the grading. And in grade 1 to 2, you need antibiotic, and grade 3 to 4, you need antibiotic along with surgery.
Okay,
So this is the combination of these two bugs.
okay, okay. Less than two ultrasound, and then UG or whatever. Two or more observation. That's for first. Recurrent ultrasound and then UG. Okay. Jesus. This I feel like this is gonna come on the exam and I'm gonna be there like, oh my god, the box. Um 4-year-old boy. Oh wait, did you read it? I think you
Oh
did,
no.
yeah. Oh no, sorry.
Recurrent urinary tract infection in children increase the risk of renal scarring and hydronephrosis. Hydronephrosis is the finding of the VUR, and renal scarring is the complication of the viewer. And chronic kidney disease, vesicoureteral reflux, is characterized by incomplete closure of vesicoureteral junction during voiding with retrograde flow of urine from the bladder to the uterus. Sorry, uterus. Viewer
No,
allows. Sorry.
no, you didn't say anything.
Viewer allows for retrograde transport of the bacteria to the upper urinary tract and is a significant risk factor for pyelonephritis. The diagnosis is established by voiding cystourethropy, which involves installation of the dye into the bladder by catheterization. Installation of the dye in the catheterization and allows for visualization of the reflux during voiding. Oral antibiotic prophylaxis is indicated for children with viewer who presents with more than one UTI. Surgical repair of the viewer may be warranted for children with recurrent UTI and despite oral antibiotic prophylaxis. Okay.
Okay. Yeah. A 4-year-old brought to the physician by his mom because she's concerned that he's having difficulty making friends. The mother reports that he attends preschool but does not socialize with other children and spends most of the time playing by himself. At school, he's only interested in blocks, reports how tall he can build towers, and resists other activity. At home, he spends hours building towers out of block in his room and becomes very upset if he's interrupted. Like autism. He does not talk about any of his classmates. When his mom invites another child to the house, he has little interest in socializing. The mother reports that he understands directions and communicates without difficulty, but has never been very affectionate. He's generally well behaved, but will have a temper tantrum if daily routine is altered or furniture is rearranged. Pregnancy, labor, and delivery were uncomplicated. He has reached all appropriate motor milestones. His mother does not recall any language emerged somewhat later. Does not recall if language emerged later in him than it did for her daughter, but knows that he makes his needs and wants known without any problem. He is neatly dressed, physical exam shows no abnormality, mental status, he makes no eye contact with the doctor and perseverates about the towers that he built in the waiting room. What is the diagnosis? I would say
Yeah,
autism.
okay, wait. What is
Autism.
your diagnosis?
Autism.
Yes. Do you know the another name of the autism?
Now I know it's that's
Yes.
probably
That's I was talking about. Pervasive developmental disorder. So so if we don't know the name, then it would be very problematic.
mhm.
Okay, autism spectrum disorder. Autism spectrum. So autism spectrum disorder, also known as autism spectrum disorder, also known as pervasive developmental disorder, is a neurodevelopmental disorder characterized by a broad range of signs and symptoms. Characterized by a broad range of signs and symptoms. Uh, autism spectrum disorder. Can you give me a minute? 1 minute. Okay,
Yeah.
I'm coming. So autism spectrum disorder, also known as pervasive developmental disorder. Pervasive developmental disorder is a neurodevelopmental disorder characterized by a broad range of signs and symptoms involving restricted and repetitive patterns of behavior or activities, difficulties with social interaction, and difficulties with communication. Children with autism often display a lack of interest in socializing, failure in empathy, and challenging behavior. Children may also Children may also display a restricted range of interest, excessive concern with routine, resistance to change. The clinical manifestation of uh, autism spectrum disorder, typically present by the age 2 years, with delay in regression of communication, or regression of communication or social skill, impaired social recognition, mm, include eye contact, facial expression, management of autism spectrum disorder, depending depending on clinical manifestation and degree of impairment of the patient. Therapy involves behavioral development, social and educational interventions to improve social functioning and and academic functioning. Communication skill and academic function. Okay.
Okay. Next. 2 days after undergoing urgent C-section delivery because of non-reassuring fetal heart rate, 37-year-old woman, gravida 1 para 1, has onset of dysphoria, insomnia, and easy distractibility. Okay, pregnancy was uncomplicated. She has no history of serious illness, and her only medication is prenatal vitamin. Her parental cousin had MDD, postpartum onset. Vital signs are normal. Pulse oximetry room air is 97. Physical exam is fine. Mental status, she has irritable mood and tired. And concerned effect, which without treatment, which of the following is most likely to develop in this patient? Mm, it's the blue.
Okay, it's postpartum blue. We have found postpartum psychosis previously. Now it's postpartum blue. So this topic is very important. Postpartum blue are common after delivery. Postpartum blue are common after delivery and often represent hormonal changes as patient returns to her pre-pregnancy state. As pre-pregnancy state, it is typically presence. It is typically pre, it typically presents in the first few days. It typically presents in first few days after delivery with depressive. Typically presents in first few days after delivery with symptoms of dysphoria with symptoms such as dysphoria, anhedonia, irritability, insomnia, and decreased interest that do not interfere with the patient's ability to care for newborns or herself. Care to newborn or herself. These symptoms often self-resolve within 2 weeks of the onset, which is what which is what would be expected in this patient. Risk factor for development include a history of depression, cesarean delivery, and lack of breastfeeding. Postpartum blues differ from a major depressive disorder with peripartum onset in severity of the symptoms, duration of symptoms, and effect on the day-to-day functioning. Major depressive disorder with peripartum onset is associated with suicidality and should be treated psychotherapy and antidepressant medication, whereas postpartum blues generally self-resolve within few weeks and do not significantly impair function.
Okay,
Okay.
next. 32 women with asthma comes to the physician because 3-month history of progressive wheezing and cough that is occasionally productive of plugs of brownish sputum. She received the diagnosis of asthma 15 years ago. She has been taking inhaled long-acting beta agonists and inhaled steroid daily for 8 years and had good control of her symptoms until 3 months ago. She has no pets. She has no recent history of travel abroad and no new occupational exposure. She appears well and is not in respiratory distress. Vital signs are normal. Pulse oximetry, oxygen saturation 96, which I think is normal. Exam shows no cyanosis. Scattered inspiratory and expiratory wheezes are heard. Is no clubbing or peripheral edema. Leukocyte count is high. Segmented neutrophils, I believe that's normal too. Eosinophils definitely high. Lymphocytes and monocytes is fine. Serum Ig concentrations is, where am I? Ig is high. A checked X-ray shows alveolar infiltrates in the upper lung bilaterally. What is the diagnosis? So eosinophils is high and IgE is high, and her asthma is getting worse with cough and plugs. Okay.
Okay. So what is your diagnosis?
ABPA,
Okay.
ABP,
ABPA.
whatever. Mm.
Okay. Patient with asthma or cystic fibrosis are increased risk for developing allergic bronchopulmonary aspergillosis, which is hypersensitivity reaction caused by the presence of Aspergillus fumigatus organisms in the airways. The clinical syndrome is associated with transitory pulmonary infiltrate, peripheral eosinophilia, and bronchiectasis. Patient typically presents with constitutional symptoms including generalized fatigue, mild fever, progressive cough, progressive cough or progressive cough, and asthma-like symptoms that are refractory to treatment. Brown or black sputum and hemoptysis may be noted. Lab studies are notable for eosinophilia and increasing serum Ig concentration. CT chest is the gold standard for the diagnosis and is characterized by central bronchiectasis and signs of mucoid impaction. Treatment consists of systemic corticosteroid, antifungal drugs, and anti-Ig immunologics, depending on the severity and the chronicity of the symptoms.
Can you
Yes, which one?
um,
Hypereosinophilic.
mm-hmm.
Hypereosinophilic syndrome is a heterogeneous group of disorder characterized by peripheral eosinophilia. If eosinophil count is greater than 500, primary hypereosinophilic syndrome is caused by neoplastic clonal proliferation in the eosinophilic leukemia, while secondary is reactive to another process, parasitic and fungal infection is the common cause of secondary hypereosinophilic syndrome. So why ABPA?
Oh, because IgA, and usually they'll give you IgE high and eosinophils high, and then some history of asthma or cystic fibrosis. And I think we found what one question. I think it was here on the nbmes, where they gave you the chest X-ray where you could see the bronchiectasis, and the answer was ABPA. So it will be one of
Um,
those, like the
So
highest one.
bronchiectasis is associated with ABPA.
Yeah, it seems like ABP. I don't know if ABPA causes the bronchiectasis or the bronchiectasis come first and causes the ABPA, but usually they're associated. Yeah, they are.
Okay.
Yeah. Mhm. So I guess hypereosinophilic syndrome is eosinophil more than 500. Okay. Okay.
There is another confusing term like
Mhm.
hypersensitivity pneumonitis. Can you
Hyper-
differentiate?
oh no.
Hypersensitivity pneumonitis, what I have seen, like
Uh-huh.
there are some history of like pigeon, like something he is working somewhere, this type of history, like he is
Mhm.
a pigeon, he's like pigeon dealer, or he is working like he's a farmer. That
Mhm.
scenario comes with the hypersensitivity pneumonitis. Even somebody who is working with the spray paints, they can have this hypersensitivity pneumonitis.
Yeah.
Okay.
So it's like allergy to
Yes,
something.
like allergy, but the term is quite different.
The term is quite different. Okay.
Okay, another thing I want, uh, like, can you say the timeline of postpartum blue, depression, and psychosis? Like,
Oh,
there was a timeline, like onset and then uh, it resolves. Onset and
um,
resolves. Like postpartum blue onset is 2 to 3 days, and it resolves within 2 weeks. Like 2 days to 2 weeks. If you remember in that way, blue 2 days,
mhm,
2 to 3 days, and it resolves within 14 days, like 2 weeks. And
mhm,
postpartum depression, it starts typically within the 4 to 6 weeks. So twice a double of the two, like four typically starts with the 4 to 6 weeks and can be up to a year. And the psychosis is variable, like days to weeks.
okay. So I found, I
Yes,
don't know if it's with you or I saw a question where it was
yes,
saying that what you said, blues is less than 2 weeks,
yes,
postpartum depression is less than 4 weeks, and after 4 weeks, it's not postpartum depression; it's just normal depression.
yes. After
And
four,
yeah, yeah. So I don't know. So is it? Does it go to a year? So that's why
but
I'm confused.
even if, but according to the book, or according to the inner circle, like it can be up to a year, even if you diagnose it MDD, as it is postpartum period. So your drug is the antidepressant.
No,
Like
because that question was to differentiate if it was postpartum depression or if it was just normal depression. Like you had to pick.
I haven't seen such question. May be present. I don't know.
I don't know if it was with you. I don't know, but yeah, that's where I read it. Okay, okay. But yeah, you're right. Usually they will just tell you to what medication to give, and you know it's depression, so you give SSRI. Yeah. But yeah, that was a weird question. That's why I was like, okay. Because what you just said, that's what I knew. Like it can go up to I think a year
Yes,
after
it can
the yeah.
up to a year.
Yeah, but
And the MDD criteria fits. Even if
uh-huh.
you look like that, we need to do counseling and this and that, you should straight go for the treatment. If MDD criteria fits, go for the treatment, because I found that that even if like you feel like that we should counsel the patient, like in postpartum depression, in postpartum period, like their emotion is labile, so
Mhm.
maybe counseling is enough, but in here I have seen that like
Yeah.
treatment is the priority.
Mhm.
Okay.
24 woman comes to office for annual employment physical exam. She feels well. Medical history is fine. No medication. Vital signs normal. Physical exam discloses no abnormality. Physician is preparing to leave the exam room. The patient asks, "Do you think having a romantic relationship with my gynecologist is all right? Which of the following is the most appropriate response?"
So it is always unethical.
Mhm.
The relationship between physician and patient is asymmetrical. The relationship between, but not in our country.
Oh, God.
Even some of them got married also.
No, I was listening to Divine, and there is that thing, but it has to be like you are not the patient anymore and wait for a certain amount of time and blah blah blah. It was like so he was trying to explain it, but yeah, just on the exam it's unethical.
Yes, it is unethical. Yes.
Yes.
So the relationship between physician and patient is asymmetrical in terms of the authority and the trust invested in the patient, and the romantic relationship with the context exploits the vulnerability of the patient. Relationship are particularly such a relationships such relationships are particularly inappropriate when the nature of the physician patient interaction is intimate and mm, intimate, such as in obstetrics and gynecology or psychiatry. The American College of the Obstetric and the Gynecology guidelines state that the sexual or romantic relationship between the gynecologist and a current patient are always unethical and may be ground for investigation or criminal prosecution. The American Medical Association's Code of Ethics suggests that physicians completely terminate the physician-patient relationship before pursuing a romantic relationship. However, romantic relationships subsequent the physician-patient relationship may be influenced by the prior relationship, creating further ethical dilemmas. This patient who is inquiring about dating her gynecologist raised a concern for possible sexual misconduct. The patient should be informed that such a relationship is inappropriate, and a discussion in a discussion inquiring about what the patient has experienced with the gynecologist should follow. Any sexual misconduct or suspect misconduct should be reported to appropriate authorities such as medical licensing board, hospital disciplinary, hospital disciplinary, disciplinary, medical licensing board, hospital disciplinary. Where I am.
I don't know.
Okay, this patient who is inquiring about dating her gynecologist raises a concern for possible sexual misconduct. This patient should inform that such a relationship is inappropriate. A discussion about what the patient has experienced with the gynecologist should follow. Any sexual misconduct or suspected misconduct should be reported to appropriate authorities such as medical licensing board, hospital disciplinary boards, or other appropriate institutional officials. Okay.
Okay. Next. Healthy 52 men comes to the physician for routine total colonoscopy. He has no history of blood in his stool or rectal bleeding. Okay. There is no family history of colorectal polyps or cancer. He takes some medication and has never smoked. Physical exam shows no abnormalities. Colonoscopy shows 3 millimeter pedunculated polyp in the cecum. No other abnormalities are noted. The polyp is completely excised. Histopathologic evaluation shows these plastic appearing columnar epithelial cells confined by the basement membrane, lining a fibrovascular stalk. Which of the following is the most appropriate recommendation for future screenings for colon cancer in this patient?
The the United the United States preventive okay, leave it. Colorectal cancer screening for these things are hard. I have
Yes, okay.
so leave it. Colorectal cancer for patients beginning at age 45 years and continuing until age 75 years. Colorectal cancer is common in early detection and treatment has been shown to reduce the mortality. Treatment has been shown to reduce the mortality. Colon, um, Colonoscopy remains the gold standard screening test as it allows direct visualization and excision of the polyp the length of excision of the polyp throughout the length of the colon. Other direct visualization test is flexible sigmoidoscopy. Is flexible sigmoidoscopy may be acceptable for some patients. Other testing strategies include stool-based tests such as fecal local blood and fecal immunochemical test and CT colonography. A variety of the test intervals are acceptable and recommended by national governing bodies, with many patients undergoing either colonoscopy every 10 years, annual fit screening every 10 years with flexible sigmoidoscopy and fit and screening every 5 years with CT colonography. In this event, that adenomatous polyp or patient's colonoscopy showed a polyp or dysplasia, which passes him an increased risk of colon cancer. Colonoscopy should be repeated in 3 years in 5 to 10 tubular adenoma or sessile polyps less than 10 millimeter in diameter. One tubular adenoma or sessile polyp greater than 10 millimeter, multiple serrated polyps Adenoma, cerebral adenoma or sessile polyps, adenoma or sessile polyps with dysplasia or with villus or tubulovillus histology that are completely removed. Why we are doing colonoscopy in 3 years? That I am not understanding. If if we go through the box of the colon cancer screening, do you remember the box of the colon cancer screening?
Mm,
According to that box, it does not fit. If the patient has patients at average risk, suppose a patient at average risk and his age is 45, so patient at average risk start doing the colon cancer screening at 45.
mhm,
And colonoscopy every 10 years, guac positive fecal local blood test for every year, fit DNA for every 1 to 3 years, and CT colonography for every 5 years, and flexible sigmoidoscopy for 5 years, or col- okay, I'm coming 1 minute.
okay.
Hello.
Yeah, can you hear me?
Yes, I can hear you.
Okay. You
So
see my. Mm-hmm.
why it is patients is at average risk, isn't it?
No, they found a polyp, so he's not average. They found a
So they
dysplastic polyp.
found a polyp. The next one, like colonoscopy at age 40 or 10
Mm-hmm.
years prior the diagnosis in the first degree relative, whichever comes first, and repeat every 5 years where 3 years is written.
Mm.
You got my point.
I get it.
When
I get what you're saying.
when I will think about 5 years, when I will go through the box, I cannot assume.
It's age 40.
And if
Mm.
the patient is with ulcerative colitis, then it is 1 to 3 years. But this patient is not in ulcerative colitis. He has a clear cut polyp. They already described the polyp. So if it is
Mm-hmm.
polyp, if it is adenomatous polyp, according to the box,
Mm-hmm.
adenomatous polyp more than 10 millimeter, then the colonoscopy, repeat the colonoscopy every 5 years, isn't it?
Mm-hmm.
So where is the 3 year? That's my
That's
point.
true. That's true. So here it should be every 5 years, but it's not an option. And we know that it cannot be 10 years because 10 years will be normal.
Yes.
So you'll be between 1 and 2.
Yes, we are confused with 1 and 3.
But
And there is another, like, if you think that no, it is if we think like ulcerative colitis, in there is like colonoscopy every 1 to 3 years. Then your option would be one A and B both.
no, it's not ulcerative. Definitely, it's not ulcerative because
Yes, it is not ulcerative colitis.
I
Yes,
think you just have to yeah, delete the other ones. It's not one because there is no family history and everything he doesn't smoke, like if he doesn't have any like risk factors. Like nothing, like no family history, no nothing, no smoking, no nothing. It's just that they found like a little only one polyp. So I would have gone with 3 years because 1 year would be like you have so many. If they had said there is a family history of he smoked or he had UC in the past or something, I would have gone with one. I think that's how I just deleted all the other ones. Like
Okay.
because you're right. Like yeah, it
It
doesn't
does
fit the
not
box.
match with the
Yeah, it
box.
doesn't match with the box. You're right. You're right. Yeah.
Okay,
Mhm,
I got it.
mhm. Next. Healthy 18-month-old boy brought to for well child exam. He was born 37 weeks, needed no resuscitation, and has no neonatal problems. He was fed formula for the first 2 months of life, and then his mother studied substituted cow's milk because the expense of the formula. Mm. He has received no supplements or medication. Exam shows no abnormalities. The child is at greater risk for which of the following?
So this patient, so neonates and infants fed only the whole cow's milk are at risk for developing iron deficiency anemia. Both, both breast milk and cow milk contain low mm, concentration of iron. Iron in the breast milk has high viability, while bovine proteins impair iron absorption. So bovine protein impairs iron absorption in human infants. In addition, poor absorption cow's milk is associated with increased hema- cow's milk is associated with increased occult enteric bleeding that contributes to iron loss during infancy. Most infants eventually tolerate cow's milk later in life. Iron deficiency anemia early in life can lead to significant neurocognitive and psychomotor impairments that persist even after treatment.
You read CDAE,
Yes,
CDE. Mhm.
protein calorie malnutrition encompasses a broad range of clinical presentation caused by severe deficiency in total body protein and caloric intake. Infant and children may present with failure to thrive, muscle atrophy, stunted growth. Vitamin B12 deficiency results in megaloblastic anemia, which presents with macrocytosis and hypersegmented neutrophil. It is common in patients who chronically abuse alcohol or in patients with raw and Y gastric bypass, Crohn's disease, or malabsorptive disorder. It is not associated with substituted cow milk feedings. And vitamin D deficiency in childhood or rickets commonly results from low exposure to ultraviolet radiation or low dietary vitamin D intake, particularly from low vitamin D in the breast milk. Signs of protein calorie malnutrition are not present. Okay.
Okay, so breast milk has low iron and low vitamin D, and
Yes.
normal milk only has low iron. Okay.
Yes.
5-year-old girl brought to the physician as a new patient for an exam prior to starting kindergarten. He was noted to have uh, high blood pressure by previous physician 3 years ago. Her BP 2 years ago was normal. She was not seen by a physician since that time because her mother did not have health insurance. The patient is at 50 percentile for height and 15% so small, skinny. Temperature is fine, pulse is fine, respiration high, blood pressure super high. Breathe is heard over the right aspect of the mid-abdomen. No other abnormalities are noted. Renal arteriography shows stenosis of the right renal artery. Which of the following is the most appropriate next step?
Secondary hypertension, uh, hypertension secondary hypertension, in contrast to primary or essential hypertension, accounts for a greater proportion of hypertension in children than in adults. This commonly occurs as a result of kidney or renovascular disease, including renal artery stenosis. Reducing in renal perfusion leads to activation of renin-angiotensin cascade, with subsequent increase in renal volume retention and blood pressure. Renal artery stenosis in children may be isolated finding, or it may be associated with fibromuscular dysplasia or neurofibromatosis type 1. Treatment option for secondary hypertension associated with renal artery stenosis in children include calcium channel blocker or angioplasty. Calcium channel blocker are generally preferable to other agents such as diuretics or angiotensin receptor blockers, both of which can result in reduced glomerular filtration and greater risk of high and greater risk and greater risk for hyperkalemia. Angioplasty is observed Angioplasty is reserved for patients who fail oral antihypertensive treatment. So in case of renal artery stenosis patient, angioplasty is done if if treatment cannot solve the problem.
Mm-hmm,
And
mm-hmm,
there is another question we have found in renal artery stenosis, like in bilateral renal artery stenosis, if you add the ACE inhibitor, then your kidney functions start deteriorating, isn't it? We can
mm-hmm.
give ACE inhibitor in unilateral renal artery stenosis, but in bilateral renal artery stenosis, your kidney function, like your creatinine, starts rising.
Yes. Mm-hmm. 42 woman, Gravida 1, Para 1, comes to office for routine exam. She is concerned about her risk for coronary artery disease. She has irritable bowel syndrome and migraines. Medications are somatetan, ibuprofen as needed. Father had hypertension, hyperlipidemia. Her paternal uncle was diagnosed with coronary artery disease at 50 years old. The patient smoked for 10 years but quit 7 years ago. She drinks 2 glasses of wine weekly, no drugs. She runs 3 miles 1 to 3 times weekly. She is BMI is fine, and she's 5'6". Blood pressure is fine, I guess. Exam shows no abnormality. Results of fasting serum studies, glucose, I believe, is fine. Cholesterol is high. Let me double check. Yeah. HDL is high. LDL is it's normal. And tags is normal. Okay. The risk assessment score for her 10-year probability of coronary artery disease is 0.4%. The patient is counseled about maintaining a diet low in fat and continue her exercise program. Which of the following is the most appropriate next step?
Okay. So no intervention is indicated at this time. Cardiovascular disease, including coronary artery disease, is a major risk factor, um, is a major cause of morbidity and mortality in US. Risk factor include development of obesity, tobacco use, diabetes, malaria, hyperlipidemia, poor diet, lack of exercise, modifying These risk factor with lifestyle changes and or medications can decrease the risk for development of coronary artery disease. However, medication can be associated with adverse effect, and their initiation should be guided by the evolution of the risk and the benefit in each individual patient. This patient has evidence of hyperlipidemia with increased total cholesterol and LDL cholesterol concentration. In general, if LDL cholesterol concentration is below 190 mg per deciliter, the decision to start a statin or HMG reductase inhibitor is based on 10 years cardiovascular risk. In a patient with cardiovascular risk or less than 5%, the risk of statin medication often outweighs the benefit. In contrast, if a patient's cardiovascular risk is greater than 10%, starting a statin medication is indicated. Initiation of aspirin follows similar rationale, with the risks outweighing the benefit in those with low cardiovascular risk. Therefore, while this patient has hyperlipidemia, no further intervention is indicated at this time.
Unit B,
B.
B as in boy.
Yes, daily aspirin therapy is indicated for primary prevention in those with 10 years cardiovascular risk greater than 20%. Uh, I think that they are meaning that ASCVD, atherosclerotic cardiovascular risk, there is a calculator, ASCVD risk is seen on that thing. If it is more than 7.5, we start the HMG reductase inhibitor like statins. And if it is more than 20, then we do the aspirin. Yes, this one. Uh, you move upward, not
Where
triglyceridemia. There is a like primary prevention of the statin.
primary prevention of the statin.
Like we are giving it is, yes,
This one.
this one, yes. So for primary prevention, look, the estimated 10 years, they are talking about 10-year cardiovascular risk, like third option. So like estimated 10-year ASCVD, if it is more than 7.5 to 10, then you should start statin. There are three criteria for primary prevention: LDL more than 190, age more than 40 with diabetes mellitus, and third one is estimated ASCVD. If it is more than 7.5 to 10%, then we should add statin, even if he has not any insult of any cardiovascular disease. And if somebody has established ASCVD, like if hey, somebody has acute coronary syndrome, stable angina, revascularization is done, stroke TIPAD, then uh, you should continue the study.
Next.
An aspirin for 10-year cardiovascular risk greater than 20%. Okay.
Investigator would like to determine if a new medication for COPD decreases hospitalization rates in adults who come to the ED because of exacerbation. All patients with COPD who come to the ED because of exacerbation will be invited to participate in the study. Patients will be randomly assigned to receive a new medication for standard therapy or standard therapy alone. During the hours that a study nurse is present, 7 a.m. to 7 p.m. Patients who come to the ED outside of these hours would not be enrolled in the study. Physicians treating the patients will be blinded to the group assignments. Okay, outcomes will be assessed by physician not involved in the care of the patient. Which of the following is the greatest limitation of this study?
Okay, generalizability. Generalizability refers to the ability to apply the results of study. Refers to applies results to a study conducted with sample population to the population at large or and reflects the external validity of the study. Generalizability or external validity can be affected by various factors such as sampling bias or Hawthorne effect or Hawthorne effect. In contrast, internal validity describes the ability of a study to attribute its finding to cause-the-effect relationship under study, which also excluding alternative explanation for the observation, while rigorous experimental design and standardized procedures are important for establishing. Mm, okay, can you explain this? I am lost.
Oh, can
The
you finish reading first so I I cannot. You finish reading first?
okay,
Yes.
I am reading it again. Okay. Generalizability refers to the ability to apply the result of a study conducted with a sample population to the population at large and reflects the external validity of the study. Generalizability or external validity can be affected by various factors such as sampling bias, in which the sample population does not affect the population at large, or the Hawthorne effect, in which the sample population alters its behavior in response to testing or awareness of being under the study. In contrast, internal validity describes the ability of the study to attribute its finding to the cause-effect relationship under study, while also excluding alternative explanation for the observation. While rigorous experimental design and standardized procedures are important for establishing internal validity, choices that are affect experimental design may result in poor generalizability or external validity in the scenario choosing the sample patients who present only patient who present to the emergency department while a study nurse is present during the day ensures that there is standardization of the care but creates a sampling bias that limits the generalizability since patients in this population at large and also present at night. Can you please explain?
Okay. I think it's just saying that um, generalizability means that you take a sample that's representative of the real population. So the real population of people with, I don't know, cardiovascular disease is like less. I'm just saying whatever. It's not true, but let's say the real population the real population that they want to study, more male, all male have cardiovascular disease. But in their study that they're doing, the clinical thing, they're picking young females to study cardiovascular disease. Then that's not the representation of the real population that they want to study. So that's what they're saying here. They're saying that the sample that they pick for to do the study is not a representation of the real population because they are only picking people at a specific time, 7 a.m. to 7 p.m. But the real population that has the COPD is like may present even at night, even after 7 p.m. or before 7 a.m. You know,
Yes.
like yeah. So maybe the people that are presenting between 7 a.m. to 7 p.m. are people that have moderate, like small COPD. But whereas the real population has like severe COPD, but you are not catching them because you are only picking in that specific time, 7 a.m. to 7 p.m. That's why they're saying that. So you cannot apply um, this study to the real population because you are not really sampling from the real population. You are like,
So we
ex-
cannot like use the time uh, like 7 a.m. to 7 p.m. Like if somebody is doing office hour, like
mhm,
his office starts at 7 a.m. and ends at 7 p.m. And apart
mhm,
from it, he is not taking the sample. So we
mhm.
cannot use this kind of data also.
You cannot. It's really restricted. I think they're saying here that this thing is so restricted that it may not represent the actual people
Act-
that have. Yeah, because you are putting too much restriction in it. You know.
Okay.
Yeah, I think that's what they're saying. So it may not represent the real population of people with COPD in the real world, whatever in the real world over there, because you're putting too much restriction.
Okay, that
Yeah.
makes sense.
Okay. Next. 57 men brought to the ED by his neighbors who found him lying unconscious in the puddle of vomit in his apartment. He has 20-year history of alcohol abuse and on arrival he's lethargic and reports shortness of breath. Is unable to provide medical history. Temperature is high. Pulse is, I guess, normal. Respiration high. Blood pressure, I guess, normal. Diffuse crackers are heard bilaterally. Blood gas analysis. pH is normal. Let me see if I'm right. Yeah. PCO2 is low and PO2 is low. An X-ray of the chest shows pulmonary infiltrates bilaterally. Which of the following is the most appropriate next step
Isn't
in
it rest?
management?
Alkalosis. We cannot say it respiratory alkalosis.
No, I mean, not really. I don't think it matters here, but I don't think you can say
P oxygen level is low. PCO2 is reverse. Okay.
it's low too.
And X-ray show pulmonary infiltrate.
Mhm.
There is fever. Okay. That's
There is there is fever.
so patient. This patient is suffering from ARDS. This patient is likely suffering from ARDS. ARDS is characterized by acute onset diffuse inflammatory lung injury and bilateral pulmonary infiltrate, diffuse inflammatory lung injury and bilateral pulmonary infiltrate on chest imaging, leading to hypoxic respiratory failure. There are numerous causes, including sepsis, especially in the setting of gram-negative bacteria caused by macrophage overactivation of the lipopolysaccharide pneumonia, chemical pneumonitis aspiration likely in this case with the possibility of bacterial aspiration pneumonia, pulmonary congestion, acute pancreatitis, trauma, transfusion, medication, amniotic fluid embolism, alveolar damage and inflammation lead to increased permeability and alveolar capillary interference. Urgent endotracheal intubation should occur in patients who are apneic, hypoxic, unable to protect their airway, lethargic, no gag or cough reflex, or hypercapnic and not responding to less invasive means. Intubation and mechanical ventilation is most appropriate next step in the management of this patient to secure the airway and ensure adequate oxygenation and ventilation.
You read A and
A.
D as in donkey. A and D.
Hyperbaric oxygen therapy is indicated in carbon monoxide poisoning. Symptoms of carbon monoxide poisoning: there is headache, lightheadedness, nausea, altered mental state. Acute management involves removing the patient from the exposure and treatment with 100% supplemental oxygen to dioxide to displace carbon monoxide from hemoglobin. Severe cases severe cases and high risk patients demonstrating any degree of neurologic deficit or significant head organ dysfunction should be treated with hyperbaric oxygen therapy. And C is IV administration of the methylprednisolone in the treatment of
Oh
allergic.
no, D as in donkey.
Oh, okay. Bronchoscopy with lavage can be indicated in the diagnosis of some patients such as TB and pneumonia. The patient should be immunocompromised, making this infection less likely. Okay, I have an important call. Can you give me 5 minutes?
Yeah.
Okay.
Okay.
The patient is likely suffering from ARDS. ARDS is characterized by acute onset, diffuse inflammatory lung injury, and bilateral pulmonary infiltrate on chest imaging, leading to hypoxic respiratory failure. There are numerous causes, including sepsis, especially in the setting, especially in the setting, especially in the setting of gram-negative bacteria caused by macrophage overactivation by lipopolysaccharide. Pneumonia, chemical pneumonitis, aspiration likely in this case with possibility of bacterial aspiration pneumonia. Pulmonary contusion, acute pancreatitis, trauma, transfusion, medication, and amniotic fluid embolism. Alveolar damage and inflammation lead to increased permeability of the alveolar capillary interface. Urgent endotracheal intervention should occur in patients who are apneic, hypoxic, unable to protect their airway, lethargic, no gag or cough reflex, hypercapnic, and non-responding to less invasive means. Intubation and mechanical ventilation is the most appropriate next step in the management of this condition to secure the airway and ensure adequate oxygenation and ventilation. Okay. Okay, I have read this because as far I remember hyperbaric oxygen. Sorry, hello.
Yeah, I can hear you.
Yes, I
Mhm.
think we have read this. I have read this.
Okay. Next. 37 women scheduled for arthroscopy repair of a right medial meniscal tear. A procedure is scheduled. She's scheduled. A procedure is the surgeon last scheduled operation of the day. All previous procedures this day involve left knee. In the operating room, the resident prepares the left knee for operation. The operation is discontinued after the surgeon discovers no meniscus tear, and the patient is informed about the error. Which of the following is the best approach to prevent future errors of this type?
So wrong side surgery is rare but potentially catastrophic from the surgical error that is likely to result in malpractice litigation. Wrong side surgery can result in potentially serious harm such as inappropriate amputation or unnecessary surgery. Procedures for preoperative verification and surgical markings are essential in preventing wrong side errors. Physicians should be familiar with the Joint Commission Universal Protocol for preventing wrong procedure, wrong person surgery. Steps include preoperative verification of the patient's identity and the procedure to be performed, and the surgical side. The patient should be involved in the verification process whenever possible, and any discrepancies or Any discrepancies or questions should be addressed. The use of checklist can assist in ensuring standardized verification process. The surgical site should be marked by the surgeon who will perform the procedure, and the surgical mark should be both unambiguous and positioned such that it will be visible after the surgical trap is placed. Additionally, a final verification timeout should be performed prior to induction of the anesthesia to verify the patient's identity, procedure, and the surgical site.
Can you read D as in donkey?
Yes, having the surgeon review the chart, review having the surgeon review the chart just prior to the procedure is appropriate but is not substitute for preoperative verification. Additionally, involving the patient directly in the verification process can greatly reduce the likelihood of wrong side errors. Like before giving the anesthesia, the surgeon uh, should be present in the OT room and talk to the patient and confirm about the right or left limb. Is that their meaning?
Yeah, I think when I did my surgery rotation,
Okay.
I was in the OR.
Yes.
So just before the surgery, but that was weird because that the patient was already asleep. But just before they start the surgery, they will do like they will call timeout and everybody will be quiet, and then that's when they will do it. But the patient was already asleep. So I'm guessing here they're saying the patient should not be asleep on that timeout. But on top of that, before the patient even get to the room, like you're saying, the doctor should already talk to the patient and confirm everything on top of also the timeout. So it should be like two verification kind of things. I think that's what they're saying.
Like before entering into the OR, sorry, OT, and before induction of the anesthesia, two times.
I'm thinking this is what they're saying. I've
Okay.
only seen the one before in no, the one that I've seen, the patient was already inducted. He was already, under anesthesia. So I think, yeah, but here I think they're saying before anesthesia and before the OR. I
Oh,
think that's what they're saying here.
okay.
Yeah.
It is not usually done.
It's not like I said, mine the patient was already asleep. Now
Yes.
I don't know before the or before they brought the patient to the OR, maybe the doctor saw, maybe they did it and I wasn't there. But in the OR, like the patient was already asleep when they did the timeout.
Yes.
So I don't know. I guess it depends. Okay.
Even some of the busy surgeons in our country, like some like patients is already under anesthesia, and the surgeon enter
Yeah.
into the room, and
Yeah.
they see their file and start doing the surgery.
Yeah. That's usually how I think here also. That's usually. But I mean on the exam, I guess yeah, you need to know there are two types, two types to do it.
Okay.
Okay, can we stop here?
Yes, yes. Extremely
Okay.
sorry for the delay and
No worries, no
like
worries.
like